name is Stuart Flint. I am president of Scaled Insights, an artificial intelligence company based in Leeds. I'm also associate professor of psychology at the University of Leeds. I'll be presenting first up as part of this webinar, and then we will also hear from National Voices and Ipsos MORI. I'll just pass over quickly to Charlotte as a quick introduction.
Hi, my name's Charlotte. I'm Chief Executive of National Voices. We're the umbrella organisation for charities in health and care.
Thank you, Charlotte. And then Lucy and Ellie.
Hi, I'm Lucy. I'm a business anthropologist and I specialise in healthcare and financial services research. And I'm here with Ellie.
Hi, I'm Ellie Tate. I work with Lucy at Ipsos. We're healthcare ethnography specialists.
Lovely. Thank you all. And so just to let you know what the format's going to be, so we'll all present. We'll take a couple of minutes to answer some very quick questions between the sessions, and then at the end there'll be a little bit more time for further questions, which could be posed to all of the presenters. Okay, so without any further ado, I will move on into our presentation. To start off with, I've got the pleasure to present one of our COVID studies on behalf of my co-authors, as you can see here. And this was looking at the impact of COVID-19 on people identified as at high risk. And when I refer to high risk, this is the high risk groups that were identified by UK government at the start of the pandemic. So hopefully most of you will be aware of what those groups are, but they were people aged 70 years and above, people who are pregnant, and then a range of different chronic health conditions, such as diabetes, kidney disease, HIV/AIDS, and so on. What we also did here was include people who identified as at high risk but weren't identified by the government per se. So we also had people with acute health conditions who felt that they were at high risk from COVID, and also other chronic health conditions. We also had, for instance, people who have mental health concerns who participated in this study. As a very quick background, so of course we know that the pandemic has had a wide-ranging impacts on people. Early on, and even still now, we've started to learn a lot about the impact on people more generally across the population. There's been publications that have emerged that have looked at the impact, of course, of the direct impact of COVID-19 infection, but also the indirect impacts of restrictions, those restrictions being, of course, lockdown. But what we really wanted to explore here is the impact on this group. And this is because, of course, with these additional restrictions and guidance placed on people in the high-risk groups, we perceive that this impact is likely to be greater, but there certainly is a paucity of evidence that's giving us some information here. Because of the nature of the high-risk groups, we were particularly interested in how this was impacting people's access to healthcare, whether this was impacting people's management of their health conditions, and also, of course, whether this meant that they were changing the way that they were managing health conditions, either from being directed by healthcare or independently were changing their management of healthcare. And of course, also the use of technology. Now, of course, for some groups, there were technological platforms that were already available. For others, there weren't. And of course, since the start of the pandemic, this has likely changed. There's been many new technological platforms that have been developed to support people during this time period. What we've also seen in terms of general population information is a lot of information showing how the pandemic is impacting people's mental health and also lifestyle behaviors. Again, we haven't seen a lot of information about how this is impacting the group, the high-risk group. And finally, there hasn't been, and even now, to our knowledge, there's only a couple of studies, one of which was actually a piece of work that we've conducted ourselves, looking at the use of artificial intelligence, which might glean greater insights to support our knowledge and understanding of the impact of the pandemic on people. So what we did was we created an online survey. We refer to this as the AAA Survey Awareness, Attitudes and Actions Survey. And we disseminated this survey to people through a number of different routes, with a lot of support from many different charities, health charities, which we're extremely grateful for, who disseminated to members. You'll see on the right where people live across the UK. We've got quite good coverage with 1,250 respondents. 61% of the respondents were female, 95% white, with a mean body mass index of 28.8. There were 5 sections to our survey. So the first section was about awareness, awareness being awareness of what COVID is, what the symptoms are, concerns about COVID. So these concerns were, of course, concerns about infection, illness, and death, spread to other people, the impact on the economy, impact on access to healthcare, risk mitigating behaviours. So were people using protective apparel, were they social distancing, online shopping, and so on. So B, management of health conditions, access to healthcare, use of technology. Section C, impact on mental health, depression, well-being, and we use some validated measures there. Section D, the impact on health and lifestyle behaviours, so alcohol consumption, quantity, quality of sleep, physical activity amount and type, and finally impact on diet. And then the final section is how it was impacting people's interactions with others, and any experiences of stigma. Because of the time limits of today, I don't have time to talk through all of these, so I'm going to highlight some of the areas in particular to talk to. I'll present some of the statistical findings. Also, I'll provide some qualitative quotes. We have masses of data here, so this certainly isn't exhaustive. I'm happy to share further information with you. And then finally, I'll talk to some of our AI findings. So the first bit of information that I'm going to present here is about some of the concerns that people have about COVID. There are 6 different concerns, as I've mentioned on the previous slide, that we were looking at. Here on the left is the concerns relating to illness and death. And what you can see here is across all of the different groups, there's high concern. So this was really just a 0 to 10 response scale. And you can see that a lot of people are reporting that there's high concern, which of course shouldn't be a major surprise. And of course, that also meant that there was, in terms of statistical significance, there was no significant differences in terms of the level of concern between these groups. That's not to say that people weren't concerned. They were concerned. They were very concerned. And that was evident across all of the different high-risk groups, with maybe 1 or 2 exceptions. You can see with the people who are pregnant, there's a few more people who are less concerned. But in terms of health conditions, certainly high concern across. So no differences based on, for instance, spread of COVID to others. In terms of concerns, spreading COVID to other people was where we saw the highest concerns, and that's what people are most concerned about, is passing COVID on to other people. No difference in terms of receiving care and support, or potentially receiving disparate healthcare support compared to other groups. So really high concerns across the groups there. Where we did see some differences were in people with chronic respiratory disease, who were significantly more concerned about accessing healthcare support compared to other groups. But the main message here is to show that there's a lot of concern across the different groups, across the participants. And to provide a little bit of context there from some of the open-ended responses, I'll just pick a couple here, but these are representative of the first kind of 10% of qualitative information. As I say, we've got masses of data to call upon. In the bottom left-hand corner, so a lot of people talked about being concerned to the point where they were concerned about dying. And that really seemed to reflect a lot of the messages they were receiving from media and others. Some of you may have seen messages, particularly around the impacts of COVID on people living with obesity. There has been a steady undertone of information that has suggested that, and actually there are some quotes that have been pulled, which are highlighting the risk of death to people with a body mass index of 40 or above, i.e. in that high risk category. So in this instance, the person talking about being scared of leaving my family if I die. In the middle, you can see that people, again, this person is saying that they're very concerned, and it's obviously impacting their their healthcare management. And then in the bottom right, being concerned about the delay in being scanned, being concerned about a return of cancer. So again, concern is very high, anxiety is like to be extremely high. Here, I just wanted to present this Wordle, or this word cloud. One of the questions, one of the open-ended questions, we've got 17, one of the questions was, how do you feel about being identified as at high risk? So it's really just their response to being in a high-risk group. And what you can really see here is that people are obviously feeling very vulnerable, anxious, scared, worried. You can really see the impact that it's potentially having on people just identifying as at high risk. I don't have time to talk about mental health in too much detail, but what we did see was nearly half of the respondents reporting that their mental health had worsened compared to before lockdown. In terms of health, access to healthcare and use of technology, again, just a couple of our kind of questions from the survey. On the left, changes to regular healthcare. As we might expect, a lot of people have been impacted in terms of their appointments, delayed appointments, cancelled appointments, and so on. Again, the qualitative information supports that. So 2/3 of people reporting an impact on appointments. Approximately a third, so 28.5% of people have been impacted in terms of access to medications, 20% clinician time, 11.9% elective surgery. Just to put that into context, that's about 130 people from the 1,250 participants in our survey, and approximately 20% saying there's no change. On the right, I labeled this technological platforms, but really it's just platforms more generally in terms of how people are engaging with healthcare. This actually contradicts one of the reports that came from governments earlier on that suggested that most people are using social media or healthcare apps to access healthcare. In our sample, what we're seeing is the majority of people are using telephone, and there's significantly more people using telephone in certain groups. Where we saw this being the greatest use is amongst people with multiple health conditions. So in the group which had 3 high-risk factors or more, people were significantly more likely to be receiving telephone care compared to others. And there you have email, social media, mobile apps, and virtual consultations. Again, I provided a couple of slides of qualitative information here just to support that. So again, I'll pick a couple. So maybe in the top right-hand corner, trying to get healthier, but my routine treatment for cancer and arthritis has stopped. This is causing increased pain. In the bottom left, renal appointment postponed for a further 4 months, and treatment for osteoporosis put on hold. And then the bottom middle, cancelled appointments for my eyes. So I don't know if they've been checked, and then later on mentioning that they've had no contact from their diabetic team. So clearly it's impacting people's regular healthcare. And then what I also wanted to present here today is how people are changing the management of their health condition independently and making their own decisions to change. So in the top left-hand corner, I've doubled my dosage of medication as a preventive measure. I just felt this was a sensible thing to do. In the bottom left, I've stopped taking my immunosuppressant drugs for the last few weeks. And then on the bottom right, somebody has obviously stopped taking one of their medications. I've not even discussed this with my medics or specialist nurses, as I feel this will express harm and castigate me. So not only are they changing their management of health condition, but also not discussing this with their health care support team. And then on to lifestyle. Again, I'm moving through the data without presenting everything to you, and I'm more than happy to share this with you at a later date. So here what we saw was a high proportion of the participants across all of the groups who were indicating that there's been moderate change in their diet, that the majority of people are doing less or much less physical activity. This is compared, of course, to before the pandemic. There's been no change in the type of physical activity for the majority of people. Again, this is not evident for all people who were, for instance, shielding. There was quite a difference in terms of physical activity, types of physical activity. And for the majority of people, they were changing their shopping habits. And when we look at the different groups in terms of comparing groups, we saw that older participants were less likely to report changes in their diets, i.e. that their diet was relatively unaffected throughout. That people with a higher body mass index, women, were reporting greater change in their diets compared to lower BMI or males, and that chronic respiratory disease, kidney disease, weakened immune system, or a higher BMI were less likely to report greater change in physical activity amounts. And so what I'm really doing here in this is presenting some of the statistical findings. I've, of course, presented some qualitative findings, but the statistical findings is based really on the demographic groupings that people fit in, as well as the high-risk groups. But of course, everybody here will be well aware that there's more to the story here than simply grouping people as based on a demographic group or a high-risk condition. And that's really what we like to explore from an artificial intelligence perspective. We want to go beyond the demographic data to really try and understand how and in what ways people are being impacted. And so what we do at Scaled Insights is we analyze language to better understand who people are, and in particular, we're assessing people's personality attributes, because that can give us a better understanding in this instance of how people may be responding during the pandemic. So what we do is we analyze language construction in particular, 300 to 500 words from each person, and we analyze the language against over 100 different metrics that map onto personality attributes, values, and sentiments. And as I've alluded to, we've got a lot of qualitative data, and so we're analyzing the open-ended responses to identify people's personality attributes, values, and sentiments in our sample. And what we can do then is turn that analysis into numbers, mathematical clusters, and using that we can then correlate whether these clusters can predict the different outcomes of interest. So this is what we've got. So actually what we've identified is that there are two distinct clusters of people based on language construction. Two distinct clusters based on, as I've mentioned, personality attributes, values, sentiments. I've referred to these as a positive and negative cluster for ease. It's not to say that there is a positive or negative cluster per se, but in this instance, based on the attributes that have been loaded more onto the two different clusters. So the top three attributes that load onto, for instance, the positive cluster, these are people who score higher on, for instance, dutifulness, cooperation, and social skills. And with the negative cluster, people who score higher on neuroticism, insecurity, and stress. That's not to say that other people, the people in the positive cluster, aren't scoring on insecurity, but in the negative cluster, it's significantly higher. Okay, so two distinct clusters. So that's interesting straight away, because it's actually saying there's only two types of groups here in terms of responses to COVID. But of course, what we want to see is, well, is that impacting the way that people are responding to the pandemic? Well, we can see that that is. And statistically, we can see that there is a difference between these two clusters. So here I'm presenting some information about the negative cluster. So people in that cluster are reporting significantly more concern about becoming infected, illness and death, access and quality of care, and they also reporting greater change in their care appointments. Now, if you think back to the concern slide, there was no difference. We were seeing that there was high concern across all the groups, but no difference. What we're showing here is that the artificial intelligence allows us to identify that actually, based on people's personality, values, sentiment from their language construction, actually there is a difference in terms of level of concern. What we also identified was in this cluster is that there's been a greater change to their lifestyle, health and lifestyle behaviors. So we see that diet and sleep has been impacted more. There's a greater reduction in the amount of physical activity, significantly lower well-being, and significantly higher depression. So actually what we're showing here is that people in this cluster are being impacted much more during the pandemic, and significantly more. So why is that important? We think that's really important in terms of how and in what ways we could be supporting people amongst the population by better understanding how people are responding based on their personality, etc., which goes beyond demographic data. So just to summarize my presentation here, what we can see across this study is that there's high concern relating to infection, illness, death, but in particular spreading the infection to others. We can see that people are being impacted in terms of lifestyle, health and lifestyle behaviors. They're clearly changed compared to pre-COVID. I think we know that, but what we can see is there's differences based on the different groups that people are in, based on the high-risk groupings. Lockdown's clearly impacting people's access to healthcare, but what we're also showing is that it's impacting the way that people are managing healthcare, and in some instances, people independently are changing the way they manage their health condition. And of course, people are using technology to access health support. Using the artificial intelligence, we've provided some additional insights that I think could be really valuable for how and in what ways we support people in the communities. They could be really valuable for stakeholders working in this area of population health, and may also provide an additional means of how and in what ways we can support people who are most impacted during the pandemic. And then finally, I think this can support the way that we communicate with certain groups, and could also support in terms of the way that we communicate risk mitigating behaviours and planning that could address some of the high concerns that we're seeing, of course, within the study, and also can build confidence moving forward and leaving the pandemic at some point. Thank you very much. That's my presentation. So I'll maybe take a couple of quick questions. Let's see if there are.
You do have one question, Stuart. Jennifer Jones has asked, were all the respondents people with health conditions, or did carers also complete the survey?
Yeah, so it was only people who were identified in the high-risk group. So that is people with chronic health conditions, or people who are pregnant, or age 70 years and above, plus people who perceive themselves to be in a high-risk group. So as I've mentioned, mental health was not identified as one of the high-risk groups, but people who have mental health concerns were reporting that they believed they were at high risk, and therefore were able to participate in the study as well. So it's purely people in the high-risk groups. Okay, well, if there's only one question, then we'll move on, because there is time, and maybe there'll be further questions for me later on. Charlotte, I think you can.
You need to stop sharing.
Control. Yeah.
Okay. Yes. Give me 1 sec. I'm trying not to panic, and then it'll all be fine. Yes. Can you see my slide?
We can.
Super. So, thanks, Stuart. We are a coalition of health and care charities. So our members are not people who live necessarily with ill health. Our members are organisations. What happened when the first lockdown happened and the first wave kicked off was that we heard from a lot of our members that the people they're supporting having a really rough time. And I also felt early on, when still every death was being reported as a sad story, we've sadly really moved on from that sentiment, that there was a sort of degree of othering going on, that the newsreader would say a 67-year-old woman died, she had underlying health condition, or an 85-year-old man died and he had underlying health conditions. And I felt that we as National Voices could make a useful contribution by understanding what's it like at the moment to live with what's called underlying conditions, and to help put the humanity of these people back kind of on the map. Because I think there is a risk, and we've seen that really unfold now, I think, in the way that the first wave ended and where we are right now in the second wave. I think that risk has materialized, that we've become quite tribal in our response, how we understand events, and that we think it's always the other who's somehow to blame. So it's only the young people who are mixing, and they are causing these resurgence of the virus, or it's only the old people who are dying and therefore we don't need to be quite so concerned about them, or it's the South Asians who live in these big households and aren't isolating. And I think we've become quite tribal in how we read events, partly I think because we have seen an absence of explicit values-based leadership, but I won't get drawn into that. I'll just talk about the data. But the impulse of the work we were doing was to, in a way, extend our sympathies to lives that we don't necessarily live ourselves. So what we did, and I'm not able to move the slide down. Why is that? Maybe like so. Yes, I've already explained that. We did a number of things. I'm really only briefly going to mention most of this. So the Doctor Will Zoom You Now was a piece of work we did in partnership with Healthwatch England and Traverse that looked at people's early experiences of online and remote care. So if that's your thing, if you try to understand how the move to digital has been perceived and engaged with by people, that's a really good report to read. And our contribution to that was to speak to people who weren't engaging on an online platform. So Healthwatch and Traverse ran an online platform to understand people's online experiences. And we said, well, that excludes everyone who's not online. So we spoke, I think we spoke to 22 people on the phone, landlines even. Do you remember those days? And we spoke and we asked them about their experiences of being offered this kind of care and what they made of it. And then we did two more substantial pieces of work. So what we know now and what we need now are sort of, in a way, twin reports. What we know now is a meta-analysis of the surveys our members ran. So a lot of our members ran surveys of the people they support. And some of those decided it would be useful to share this data with us. 12 organizations shared their data with us. And we worked with a researcher who analyzed what those surveys all found. And that included 66,000 people's responses. So that's quite a big sample. And these are obviously all people who are in contact with health charities. So they are people who have got a considerable degree of ill health going on. Because if you're the kind of person who only has to go to the GP once or twice a year because of something, you're not really using the support of a health charity. So these are people who've got quite substantial health and care needs. And what we found in analysing this data was really quite alarming, and it resonates with a lot what Stuart has said. So I remember, for example, reading the statistics that half the diabetes patients said they had had no contact with anyone about their diabetes in what was at that point more than 6 months. So, there was large-scale service disruption. 40% of people reported that they had at one point problems getting their hands on food. That's obviously a massive number. A slightly smaller number reported they had difficulty getting their hands on medicine. It was, it's not a pretty picture. What we need now is the qualitative sister report, if you want to call it that. And that's what I'm mostly going to talk about today. We created a platform that people could talk about their experiences through, and we then analysed what people told us. And then the final report I want to just briefly mention before I dig deeper into what we need now is patient, noun, adjective, and that looks in quite considerable depth at people's experiences of waiting and delays and what could be done to make that a less horrific experience. So I've already mentioned that we've created a platform that people could go to in order to tell their experiences. We call it Our COVID Voices, and we did so with next to no budget, which is why it's not amazing, but it generated some really useful insight for us. We helped people, we communicated through our members that we wanted people to contribute to this platform, to download their experiences. And we also offered help to people who might struggle with that. And we filmed some people telling their stories. So we had someone with dementia and someone with learning disability talking about their stories. And then we also worked with organizations who interviewed people and then downloaded those interviews onto the platform. So we have a number of learning disabled, a number of blind, a number of people living with dementia who otherwise might have struggled with this platform because it wasn't, you know, it wasn't terrifically inclusive, this methodology. It covers the time between early May to, I think we locked it down in August time. We then took the first 50 stories told on this platform and worked with a researcher to help us make sense of it all. In terms of the sample of the people who contributed, we didn't collect very much demographic information, but we basically asked people to talk about what it's like to live with chronic ill health or disability. So people self-selected as people who are chronically ill or who live with a disability or impairment. And we also had a number of carers. It's not half and half, but we had, you know, a significant number of people who talked about looking after someone or living with someone who is the one who's got the health and care needs. Let me just see whether there's something else I wanted to say. We've advertised this, as I said, through our membership and a little bit on social media, but as I said, we had no budget, so we sort of waited for people to wash up. The software we then used to analyze the data is listed here, and the researcher, I can't quite explain it as well as she does, but she sort of did a sort of manual sense check of the stories people told us, and we ended up with a list of topics that we then tested with the people who had contributed to the website. And that list of topics included topics such as healthcare disruption and difficulty accessing support, but it also, there were quite a lot of stories around food, around childcare, around pain, around employment, housing, wider family issues, loneliness, mental health. So it wasn't just about, we didn't just limit it to sort of clinical questions or healthcare questions. And then because we asked people whether it would be okay for us to recontact them, so we did, a lot of people, majority of people were happy with that, and so we convened 2 focus groups. The first one, we wanted to test this list of topics and ascertain that there weren't any gaps or that there were experiences that we had missed. But in honesty, it was quite a splurge, that first focus group. We caught people in June, and it was just as the first lockdown was lifting, and people were angry and they needed to vent. So we just let that run, and then kind of did a sort of offline email type exchange around the topic list. And the second one, we asked them to help us produce some statements about what good care should now look like. So as I said, a lot of the concerns weren't necessarily health specific, but we are traditionally, National Voices has only ever worked in influencing the NHS. So we focused our development of I-statements on what health and care services now need to do. But in parallel, we've done quite a lot of campaigning since around the employment rights, particularly of shielding people, which is quite a departure for National Voices, but it struck us that you can't sort of ask people to tell you what's going on for them and then go, oh, that's really interesting, but we were only interested in that bit. You know, we're not a research organization, we're an influencing outfit, and therefore we felt we had been asked to do something about employment, because it was, and it still is, a massive issue. It was feels slightly less urgent during the furlough, because the furlough has now been extended, but the furlough was meant to end in October, and people who were told that they were extremely clinically vulnerable did not know what to do about work and what their benefit entitlements would be. And we pressed government really hard, all parts of government, on police defining what people's entitlements were. And we were told people might be able to claim statutory sick pay, which is obviously a very unsatisfactory answer. But most of our work since has been around trying to define what health and care now need to look like. And that's what I'm going to share with you now, because we turned these into a set of I-statements. And there are 8 new I-statements, and so that you can read the words. I put 4 on this slide and 4 on the next slide. So the first slide, the first I-statement is the one that participants in our focus groups decided was the most important one. and because we asked them to prioritize them as well. And that took also the longest to get right, because people felt very strongly that it wasn't about being able to just splurge your stuff. It was about someone actually listening and doing something about it. So there's something there about autonomy and accountability and control, I think, that we were trying to get at with this expression of this I statement. Hence, it's slightly wordier. The second one also kind of references rights. But what really surfaced there was a lot around social protection, because people who were worried about, for example, the return to work, because they had been told they're clinically extremely vulnerable and they were maybe working in a nursery or in an old people's home, or we spoke to someone who was a pest controller and had to go in and out of people's houses. They were basically told that it was their choice as to whether they returned to work. But if they chose not to return to work, they would in effect be destitute. So people were basically saying, don't talk to me about my rights if you don't protect my ability to actually make those decisions. So it's obviously not a true choice. You can go to work or you cannot go to work, but if you don't go to work, you starve. So, you know, this is what this is sort of getting to. The third one is, you know, hardly surprising. People felt utterly bewildered by the information that was provided to them, particularly those people who are clinically extremely vulnerable. The initial correspondence people received was at times late, it was contradictory, it came stumbling out, it was corrected and changed. It didn't address a lot of the practical concerns people had. People felt really unsupported by the information they were given. And that doesn't even go into the fact that we still don't have British Sign Language interpreters when the government makes big announcements and all those special needs. This was just the general malaise of information giving. The fourth one is a sort of sub-statement, really, because it is about information and communication about risk. And that obviously was massively important to people. And by that, I meant the risk that their illness or their chronic condition presents. I have kidney failure. I had a double lung transplant as a child. What is my risk, which people felt hadn't been explained to them and they couldn't talk to anyone about? And the other one is the risk of everyday activities. So, okay, maybe my workplace is safe because I don't know, I work in an office space on my own, but my commute, what about my commute? You know, people really wanted to understand what are the risks of engaging in different activities. And when we said to them, who do you need to have this conversation with? The people with quite significant health needs felt that should be the specialist who looks after them. So if you're a kidney patient, transplant survivor, you feel that your transplant doctor needs to talk to you about this. Not that many people felt that could be done by the GP. And we have taken this ask both to GPs and specialist doctors, and they said, we don't know. It's kind of obvious that people want to know this stuff, but we really don't know. So it creates a bit of a dilemma that people have these questions and they want answers from doctors, and doctors kind of say, we have no idea. So, you know, what do you do with that? And those are the last four I statements. The fifth one is sort of, I call it our hardy perennial of the health policy world. It's never gone away. It's about care coordination. So that's obviously, as you know, as long as the NHS exists, it's been a problem. But it felt more pertinent now because people had got a letter that said, you were supposed to have a kidney, you were supposed to have a hip replacement next month, this is now cancelled. And they did not understand whether they were still under the care of a consultant, whether they needed to go back to their GP, who's in charge, what about their health, what about their pain. They had no idea who's in charge and how to get hold of that person. So it's sort of always been around, but this is a COVID flavoured one. The sixth statement is very clearly COVID specific. And what we heard there very clearly was people need reassurance, but the one thing that is really reassuring is if the service provider provides detailed information about how they keep you safe. And what I've taken away from that is a glib statement that we will do everything to keep you safe does very little to reassure people. But what people were saying they wanted was, you will be asked to sit in the car park and wait until you get called in. The person who you will see will be wearing a mask. You will need to wear a mask. If you don't bring one, we give one to you. The room you will be seen in will have been disinfected 20 minutes earlier. And I don't believe that people necessarily retain all this information, but my sense was from talking to people, they wanted to feel someone had gone through the thought process and they were telling them how they dealt with all these risks. And I think there's something there that we need to get much better at. If we want to deal with inequalities of uptake, which are really quite worrying now, who asks for NHS treatments right now and who gets them? It's very unequal, has always been unequal, but it's even more unequal now. We need to get that right. I really feel we need to really reassure people in ways that they can hear. The seventh one is the one that we then kind of used to do some bespoke work on people's experiences of waiting, because it's been such a big thing we've heard, is that people feel completely abandoned and haven't gotten any idea who's in charge, don't know how to get hold of this person, don't know what they could do in the meantime, don't know what to do if they deteriorate, feel very alone with deteriorating symptoms. And it's something that it's easier to get the information and support package right for people who wait for a hip replacement than it is to do all the hip replacements that need doing. So let's get this right, the information and support that people need. And then the eighth one, which is my favorite one, I like the guy on the little mobility scooter, is the one that people said was the second most important one in their view. And I think that was also the moment we caught them at, because it was the lifting of the lockdown. And the difference was opening up massively between the lives of people who aren't clinically vulnerable and the lives of people who are. Because you will remember the first lockdown, we kind of all shielded, didn't we, to an extent. You know, some of us might have gone to the supermarket occasionally, but we certainly, you know, we didn't socialize or anything. And so the differences in our vulnerabilities were somewhat masked during that very acute phase, whereas as restrictions lifted, people were so anxious that they would be forgotten. And the early decisions around the lifting of lockdown, you might remember some of them coincided with a certain person driving for a whole day up north and testing their eyes and all that. People felt that the early decisions around the lifting of lockdown were politically motivated, and that their concerns, and that they still felt really vulnerable, weren't really the major thing that informed these decisions. So I remember reading these really difficult experiences people had written on our platform, and the government, one of the first things they announced they were lifting restrictions around was car showrooms. And I thought, here is someone with a severely disabled child who can't get anyone to come to the house and help them, but we think we need to open car showrooms. You know, I think this sort of jarring experience of what's really important around here coloured a lot of what people told us. So the other thing, and I'm really just going to wave this in front of you, the other thing we did is that we tried to turn these statements, because we think these statements are quite moving and it's very hard to disagree with them. We tried to turn them into something practical you might actually be able to do if you either design services or deliver services. So this is just an example on information giving. If you design services, you need to make sure that you deliver information in all formats and in all languages. And if you deliver information, you need to consider these things. And then there is another example around knowing who to talk to. The evidence now around continuity of care and knowing who's in charge, that this really impacts clinical outcomes and even impacts survival, that evidence is getting stronger and stronger. It's already pretty strong. Even for something as clinically driven as cancer, it's clear that if there's continuity of care, you do better. So we feel it's high time that the health service responds to that insight and thinks about how this continuity of care can be maintained and created. Clearly no one works 24 hours a day, 7 days a week, but there are obviously ways that you can maintain continuity of conversation even if people work shifts. And it's little things, even like considering that most of the week is out of hours. and stuff like that, which is often where care coordination completely falls apart. So this is what we've learned from the work we've done during the first wave, and I'll just leave you with, where's my mouse, with a small number of questions that this sort of leaves me with, apart from how can we get the system to act on all this insight, which would obviously be nice. But there is something for me about how could we actually, as an organization that has very little resource, but loads of ideas and wonderful connections, build engagement mechanisms, ongoing engagement mechanisms that could help us take people's concerns directly to decision makers, because that's something that we do have. I do have those people's telephone numbers, and I do sit in meeting rooms with them. And how could we kind of make our engagement, our insight work much more inclusive, so that we can actually take a much broader set of concerns to decision makers? And the way I've sort of tried to coin that is, can we maybe begin to tackle the inverse care law by tackling the inverse engagement law? Because not only are you less likely to have services help you if you have very substantial health and care needs, you're also less likely to be asked what you need. And therefore, do we have a role to play as national voices in putting this right? I'll leave you with those, but you might have your own questions. Thank you very much.
Thanks, Charlotte. I'm not sure if we have any questions, but Barry, let me know if there's any questions. I've got a quick question, actually, Charlotte, if I could ask one, which, of course, could have been asked to me as well. But I guess one of the topics we are aware of and has really kind of come to the forefront right now is people who may be experiencing digital poverty, for instance. How and in what ways are we potentially able to gather insights with this group? Did you manage to do that yourselves? Because inevitably, again, it might shed some further light on how people are being impacted right now.
Yeah, no, obviously this was a digital platform. People needed to at least, know how to use a keyboard and have access to the internet. So no, we didn't hear from the really digitally excluded, apart from what I said, that we interviewed some people. We are now doing a project around people at risk of digital exclusion. And we are at the stage, we're doing a literature review right now of the grey literature in this space. So, what have Health Watchers and all those organisations found already about this? And then we're working with two organisations, one in central London, that is a sort of social support organisation. So I think if you want to hear from really excluded people, you can't do it through the health system, not even the charity health system. So we work with the Abbey Centre in Westminster, who support an unbelievably diverse community in northwest London. A lot of those people have unsafe migration status. A lot of those people don't speak English. A lot of those people have very low literacy. A lot of those people certainly don't have access to the internet and so on. So we're working with them. And we're working with the University of Bournemouth. I don't know whether they're called that. They're based in Bournemouth. They might be called something else. They have something called the Centre for Seldom Heard Voices. And they're also reaching out for us to people who are very excluded and at risk of exclusion. And through our membership, we can field gypsies and travellers, people in contact with the justice system, learning disabled people, people living with dementia, people who have an advocate, and so on. So we're at the moment gathering people's experiences of online care, and some of those conversations are very short because people don't even know what you're talking about.
Sure.
So we're kind of mapping that, and then we're also wanting to test solutions with the people we hear from, because our sector has innovated massively and come up with loads of ideas on what one could do to provide digital access, at least for some of those people. And we want to test with people what they think is useful. Is it skills? Is it money? Is it free Wi-Fi? Is it a private space? Is it a confidential pod that you can sit in? Is it advocacy? Is it translation? It'll be a combination of all those things, won't it? But it strikes me that digital inclusion is really now a dimension of citizenship, and if we don't get this right, we will exclude people not just from health service use, but from any engagement with the state, and that will have catastrophic consequences.
Yeah, I totally agree. I've just been nudged on time, but there is a question in the chat. Charlotte, if you don't mind responding to Rachel's posted a question for you, so maybe you can answer there. Based on time, let's move on. So, Lucy, Nelly, are you ready to take over?
Hi, can you hear me okay?
Yeah.
So Ellie and I are just going to do something a little different. So we're actually going to show you a film we've put together from our ethnographic research. Can you see any or?
Not sure. Barry, could you have a look, see if there are any questions? I'll ask a quick one again. Really, powerful video. And, one of the kind of key themes in there inevitably is how, people are experiencing vulnerabilities as a result of the kind of impact on finances and other. It kind of alluded to towards the end there in terms of how it might be impacting people in terms of homing and housing, and also earlier somebody was talking about reducing their pensions. How and in what other ways are people being impacted here in terms of because certainly here in the UK, and I should probably know more what's happening elsewhere in terms of what people are being supported by, but there's only so long that people could, for instance, be furloughed from work, and inevitably a lot of people are going to be returning to a workplace where either going to be made redundant or whether those jobs aren't going to continue because workplaces themselves won't still be around. So was there any kind of further information around I guess the impacts that it might be having beyond maybe pension and other?
There's so many impacts, aren't there? So there's impact on, I know you're doing some work in transport at the moment, but there's massive impact on transport for people living out of big cities. If different lines of different bus routes have been cut back, and this, for example, disproportionately affects people physically disabled and women as well, because taking kids to childcare. I was talking to the CEO of Fawcett, who was saying even the drive to get people on their bikes is a gender issue, because if women are dropping kids at childcare, if you've got two kids in hand, you can't take them to childcare and then cycle round. So I think that the impacts are massive, aren't there? There's impacts on by sector that we're definitely seeing. We've done some work for banks recently looking at people working in the entertainment sector. Just people that didn't think that they would be vulnerable have now definitely moved into that financially vulnerable category, and didn't expect it at all. And I think the financial vulnerability is really interesting because, like Sam Smethers from Fawcett was saying, that it's not until later as well that we're going to see some of these problems. So, for example, at the moment, I think women's pensions are something like, men have 5 times larger pension pots at the age of retirement than women. That's just going to massively, that gap is going to massively be exacerbated by this. So we're going to see a lot more sort of gendered issues in generations to come from this pandemic. And women have been disproportionately hit by this, and so they work mainly in entertainment sectors as well, which have been hit, and obviously BAME communities too have been massively disproportionately hit by this. So I think it's just a whole long list, isn't there, of things that we're going to see coming out of this, but not even immediately, in the future.
I think it's, sorry, go on, Charlotte.
One thing that goes through my mind is a little bit of impatience with some people who discover vulnerability for the first time as a kind of possibility. How sheltered has your life been, and what do you do with that insight? And I do think that moment of discombobulation, that you suddenly find yourself not knowing what the future will hold and what your position in it might be, is a massive opportunity to extend our sympathy outwards to people who are less fortunate than us. And we have seen a bit of that, but it could also go exactly the other way. It could go exactly towards a more tribal, a more selfish, a less considerate, a less cohesive way of thinking about, well, if it's all that dark and dangerous, I'll just look after myself and my loved ones. And I really do feel, and it's something that makes me feel really sad about where we are in the UK with this, is that we have almost wasted the opportunity to build a more a more sympathetic way of looking at each other's vulnerabilities, and to use it as a moment to say, and if you're a supermarket driver, you should be able to feed your family on that. And if you're an Uber driver, you should have sick pay if you find yourself unfortunate and ill. And I think it requires a certain kind of leadership that provides a narrative.
I was just going to say exactly that. Yeah.
You're experiencing this uncertainty, this threat to what you thought was solid. Let me explain what we're going to do about this. And I think that kind of leadership we haven't seen. And as a consequence, we find ourselves now more divided than before. And that is just tragic. And it's not going to help us with the next year, because the next year isn't over, is it? It's how we're going to deal with the vaccination, how we're going to deal with the opening of the economy, how we're going to deal with the social fallout of all this. We need every single sympathy muscle we have.
But don't you think, because I feel that we have it, and I feel quite positive about humans in general, but I think what we're seeing from our global trends work is we're calling out for leadership. Yeah, we're calling out for brands, for businesses, for government to lead us with things like climate change. People feel they're doing their bit as individuals. What they want are companies, government, local government to do, to tell us what to do and to hold our hands a bit more. And I think that's what we all want, is some hand holding and mothering slightly, and we're not getting that. Sense making, yeah. Sense
making, yeah. I think. And the leaders who've done well, where the people, the citizens have said, no, this person's actually done well. Yeah. They've done that, they have provided some narrative that makes sense to people of these crazy times. Anyway, Stuart, you probably want to wrap us up.
I think what's really been highlighted across all of our, presentations is really that people are experiencing vulnerabilities and maybe feeling at a greater risk during the pandemic, for a variety of different reasons, and clearly goes beyond some of the assumptions that clearly were made, probably nationally from a kind of central perspective early on, and the impacts are kind of wide ranging as well, whether it is around physical and mental health, but actually in many other areas of life, and that may well be across education and employment and so on, and there's so much information that of course we've gathered between the three of our institutions as such, but actually elsewhere is that needs to be considered in terms of going forward. And I think the challenge for me, and probably I would assume is what people are thinking who have attended the session, is how and in what ways we can make sure that this is is seen by the powers that be as such, and what can be learned, because I think one of the things that we haven't learned enough throughout this pandemic is what changes, what mechanisms we can implement now. What are we learning that can can support us now during this pandemic, and of course for future pandemics as well? Because clearly, as I say, there's been some assumptions that haven't necessarily been as wide ranging as they should have been, because we're really seeing the impact this is having on people's lives. Anyway, I'll stop rambling and close up. So what I just finally want to say again is thanks to Nexus for supporting us with this webinar. Thanks, of course, to Charlotte, Lucy, and Ellie for your presentations. Some fantastic information, and it's a pleasure for me to be able to not only present with you guys, but to continue talking with you and working with you in the future. And thanks for all the attendees, and I hope that it's been useful, and you've seen some interesting information based on where you're coming from. Okay, with no further ado, let's wrap up. And again, thank you very much.
Thank you.
Thank you.
Bye-bye.
Bye.